Welcome. In this session and the next, we'll be discussing about pediatric glaucomas and glaucomas in adolescence and early adulthood. In this session, we'll be discussing the individual pediatric glaucoma entities, and in the next session, we'll be discussing the general protocol for evaluating and managing pediatric glaucoma patients. Glaucomas of childhood and adolescence include a large number of rare entities causing elevation of intraocular pressure, and the elevation of intraocular pressure in childhood may cause, in addition to glaucomatous optic neuropathy, damage to the cornea and other ocular structures if the onset of intraocular pressure occurs before 4 years of age, which is very important to understand, and this figure 4 years is very important so far as management of pediatric glaucoma is concerned. And progressive myopia occurs due to increase in axial length till 10 years of age. These three features occur in both primary and secondary pediatric glaucomas, and enlargement and damage to the cornea and other ocular structures occur before and till 4 years of age because the sclera is relatively elastic prior to 4 years of age and becomes relatively rigid after 4 years of age. Diagnostic signs of pediatric glaucoma include optic disc damage, and if the onset of elevation of intraocular pressure is before 4 years of age, enlargement of cornea and globe. And raised intraocular pressure as well as gonioscopic findings are only corroborative signs which further confirm the diagnosis. The Childhood Glaucoma Research Network and the World Glaucoma Association defined childhood glaucoma as intraocular pressure-related damage to the eye and not only the optic nerve, and established the diagnostic criteria of pediatric glaucoma and pediatric glaucoma suspect. There are 5 criteria to define pediatric glaucoma, out of which any 2 must be present to establish the diagnosis of pediatric glaucoma. And this diagnostic criteria is valid for both primary and secondary pediatric glaucomas. And these 5 criteria are based on intraocular pressure, optic disc changes, corneal changes, changes in refractive error, and glaucomatous visual field defect. And these criteria are as follows: intraocular pressure more than 21 millimeters of mercury. So far as optic disc is concerned, a progressive increase in cup disc ratio, a cup disc asymmetry of 0.2 or more, or focal rim thinning. As we will be discussing, before 4 years of age there is usually generalized enlargement of cup disc ratio due to stretching of the scleral canal through which the optic nerve passes. And after 4 years of age, focal neuroretinal rim changes become more common. Corneal criteria include HAB striae, which are breaks in the designates membrane due to stretching of the enlarging cornea, and horizontal corneal diameter of more than 11 millimeters at birth, more than 12 millimeters before 1 year of age, or more than 13 millimeters at any age. Progressive myopia and glaucomatous visual field defects are also among the diagnostic criteria for pediatric glaucoma. And a patient is said to be a pediatric glaucoma suspect if the patient has any one of the following criteria: intraocular pressure of more than 21 millimeters of mercury, increased cup disc ratio, increased corneal diameter without raised intraocular pressure, increased axial length without raised intraocular pressure, or suspicious visual field defects. Pediatric glaucomas are classified as primary or secondary, and in primary pediatric glaucoma there is an isolated developmental defect in the anterior chamber angle which causes reduced aqueous outflow in the absence of any ocular or systemic comorbidity. And there are only 2 entities which are included within primary pediatric glaucoma: primary congenital glaucoma or PCG and juvenile open-angle glaucoma or JOAG. Primary congenital glaucoma are further subclassified into a neonatal form which presents between 0 and 1 month of age, an infantile form which presents after 1 month of age but within the first 2 years, and a late onset or a late recognized form which presents after 24 months of age. Juvenile open-angle glaucoma has by definition an onset between 4 and 40 years of age and so does not have any corneal or ocular enlargement. Secondary pediatric glaucomas are much more common than primary congenital glaucomas, and secondary pediatric glaucomas are classified into 4 subtypes: Those following cataract surgery, also called glaucoma following cataract surgery or GFCS, are the most common form of secondary pediatric glaucomas. The other three subtypes include those associated with non-acquired ocular anomalies, those associated with non-acquired systemic anomalies, and those associated with an acquired condition, either ocular or systemic. The term non-acquired implies the associated systemic or ocular comorbidity is present at birth. So among non-acquired ocular anomalies we have Axenfield-Reiger syndrome, Peter's anomaly, Aniridia, ectopia lentis, and nevus of Ota. And those associated with non-acquired systemic anomalies include Sturge-Weber syndrome, Neurofibromatosis type 1, Marfan syndrome, Well-Marchesani syndrome, homocystinuria, Laus syndrome, persistent fetal vitreous, and familial exudative vitreoretinopathy. And acquired conditions include uveitis, trauma, tumors, retinopathy of prematurity, steroid-induced glaucoma, and ocular surgery other than cataract surgery. And if we consider the mechanisms by which these entities cause glaucoma, persistent fetal vitreous, familial exudative vitreoretinopathy, retinopathy of prematurity, and tumors may cause glaucoma by a posterior pushing mechanism, ectopia lentis, Marfan syndrome, Well-Marchesani syndrome, and homocystinuria may cause glaucoma by a pupillary block mechanism, and uveitis, trauma, and intraocular surgery can cause glaucoma by multiple mechanisms. And if we consider the gonioscopic appearance of pediatric glaucoma entities, most pediatric glaucomas, including primary congenital glaucoma, are open angle in nature. And examples of glaucoma entities in which the angle appears closed include lens disorders, uveitis, and retinopathy of prematurity. Primary congenital glaucoma or PCG occurs due to abnormal development of anterior chamber angle structures, resulting in increased resistance to aqueous outflow through the trabecular meshwork. And this is said to be due to a developmental arrest of neural crest-derived cells destined to form the angle structures. And in some cases, maldevelopment of the Schlemm's canal is found as a cause of primary congenital glaucoma, particularly those with mutations in ANGPT1 and TEK genes. 70% of PCG cases are bilateral and 75% present before 1 year of age. PCG affects males more commonly than females, and the prevalence of PCG ranges from 1 in 30,000 to 1 in 1250 depending on race, and PCG is said to be most common in the Middle East and Eastern Europe. Genetic mutations can be identified in only 1/4 of primary congenital glaucoma patients. And genetic mutations causing primary congenital glaucoma include autosomal recessive mutations in CYP1B1 or LTBP2 genes, and autosomal dominant mutations in ANGPT1 or TEK genes. And consanguinity greatly increases the risk of primary congenital glaucoma. Infants with primary congenital glaucoma may present with the very well-known classic triad of epiphora, photophobia, and blepharospasm. This classic triad occurs because of corneal edema, which occurs due to both raised intraocular pressure and tears in Descemet's membrane, as we will be discussing. On examination, we will find enlargement of the cornea and globe if IOP elevation occurs before 4 years of age. An enlargement of the cornea and globe usually stabilizes after 4 years of age. Enlargement of the globe is also known as buphthalmos. An enlargement of the globe is also accompanied by stretching of the scleral canal through which the optic nerve passes. Corneal enlargement causes stretching of the cornea, which may lead to breaks in the Descemet's membrane, also known as habstri, and this is very important to remember. These breaks in the Descemet's membrane are typically oriented horizontal or concentric to the limbus. And following a break in the Descemet's membrane, there will be corneal edema or acute hydrops, followed by corneal opacification. Scarring occurs at the sites of these breaks in the Descemet's membrane and can persist even after clearing of the corneal edema and appear as double striae as seen here in this photograph. PCG patients usually have intraocular pressures between 30 and 40 millimeters of mercury, and an intraocular pressure of more than 21 millimeters of mercury should arouse suspicion. On gonioscopy, PCG patients show an ill-defined or absent angle recess, that is the space between the scleral spur and the root of the iris, with a high insertion of the iris obscuring the scleral spur. The insertion of the iris appears scalloped as seen in this photograph, and the peripheral iris appears hypoplastic and hypopigmented. The angle structures, particularly the trabecular meshwork, appears indistinct and translucent, and these two features, high insertion of iris and scalloped appearance of the peripheral iris, are important to remember. Optic disc changes are very important in making a diagnosis of glaucoma, whether adult or pediatric. And in pediatric glaucoma, there is usually a generalized enlargement of the cup, resulting in progressively increasing cup disc ratio when the elevation of the intraocular pressure occurs before 4 years of age. And this is because, as we have discussed, the scleral canal through which the optic nerve passes stretches, and the lamina cribrosa also bows backwards. A cup disc ratio of more than 0.3 or a cup disc ratio asymmetry between the two eyes of 0.2 or more is suggestive of glaucoma. And if IOP is controlled before 4 years of age, there can actually be a decrease in the cup disc ratio, which is also known as reversal of the cup disc ratio. But any RNFL atrophy and consequent visual field defect which has already occurred persists. Refractive errors found in PCG include progressive myopia because of scleral stretching, astigmatism often irregular because of HAB striae, and anisometropia. And with onset of IOP elevation after 2 years of age in PCG, corneal enlargement is not the predominant sign or symptom, and presenting features include progressive myopia, decreased visual acuity, and strabismus. Differential diagnosis of primary congenital glaucoma is important. Other than primary congenital glaucoma, epiphora can occur in patients with nasolacrimal duct obstruction, corneal epithelial defects, and conjunctivitis. Nasolacrimal duct obstruction is a much more common condition than primary congenital glaucoma and can occur in as many as 5% of infants, and so may coexist in a patient with primary congenital glaucoma. Corneal enlargement is also found in megalocornea and axial myopia, but in these entities, the intraocular pressure is normal, there is no glaucomatous optic neuropathy, and the cornea remains clear. Tears in Descemet's membrane can also occur due to forceps injury during birth, but these tears in Descemet's membrane are vertical or oblique in orientation, as shown here in this photograph, in contrast to horizontal or circumferential orientation of HAB striae of primary congenital glaucoma. Corneal edema in infants and young children can also occur from keratitis, keratomalacia, corneal dystrophy, and metabolic disorders, and optic nerve abnormalities such as optic nerve pit, optic nerve coloboma, atrophy, and physiological cupping may resemble cupping of pediatric glaucoma. And secondary pediatric glaucomas with associated ocular or systemic comorbidities must be differentiated from primary pediatric glaucomas. Treatment of primary congenital glaucoma is surgery following a thorough examination under anesthesia, and this we will discuss in the next session. So, as we have mentioned, juvenile open-angle glaucoma is open-angle glaucoma presenting between 4 and 40 years of age, and in these patients the anterior chamber angle appear normal by gonioscopy. Most JOAG cases are inherited in an autosomal dominant manner with mutation in myosilin or MYOC gene. Since the onset is after 4 years of age, corneal enlargement does not occur, but progressive myopia can occur till 10 years of age. Treatment is often initiated with medical therapy, but many of these patients are refractory to medical treatment and require surgery. Among non-acquired entities which can cause glaucoma, we have Axenfield-Reiger syndrome, Peter's anomaly, Aniridia, Sturge-Weber syndrome, and Neurofibromatosis type 1. These two we have discussed in the session on phacomatosis in intraocular tumor section. The glaucoma aspects of these three entities we'll discuss here, and we'll discuss these three entities in more detail in the section on cornea. Axenfield-Reiger syndrome is characterized by posterior embryotoxon, which is actually an anteriorly displaced Schwalbe's line as seen here in this photograph, along with additions of iris to the Schwalbe's line and iris abnormalities such as correctopia as seen here in this photograph and pseudopolychoria. Most cases are inherited in an autosomal dominant manner due to mutation in PITX2 and FOXC1 genes. 50% of patients with Axenfield-Reiger syndrome develop glaucoma, typically in middle to late childhood, and this is due to high insertion of the iris on posterior trabecular meshwork. The risk of glaucoma depends on the height of the iris insertion, but angle surgery may not be possible if there are many iris strands. Peters anomaly is characterized by a central corneal opacity which can be annular in appearance as seen here in this photograph, with addition of iris to this corneal opacity with or without lenticular addition to this opacity. In type 1 Peters anomaly, only iris is adherent to the corneal opacity, and in type 2 Peters anomaly, the crystalline lens is also adhered to this corneal opacity. So here we see the iris is also adhered to the corneal opacity, and this is actually a surgical iridectomy done. Most cases of Peters anomaly are sporadic, and as many as 50% of patients with Peters anomaly develop glaucoma, and glaucoma in Peters anomaly can occur in infancy, and risk of glaucoma in Peters anomaly is higher when the crystalline lens is also involved in the lesion as a cataract and or as corneolenticular additions. Aniridia is characterized by hypoplasia of the iris, which is often associated with other ocular abnormalities such as limbal stem cell deficiencies and foveal or optic nerve hypoplasia. So in this photograph we see almost total aniridia with areas showing limbal stem cell deficiency, and this photograph shows a retroillumination view in which the zonular apparatus of the crystalline lens can be readily seen. 85% of aniridia patients have a family history with an autosomal dominant mutation in PAX6 gene. The remaining cases are sporadic in nature without a family history because of new mutations in the same PAX6 gene, and 25% of sporadic cases develop Wilms tumor of kidney. And we have discussed the mechanism of this association in the session on glaucoma genetics. Early onset glaucoma in aniridia cases is due to maldevelopment of the angle structures, and late onset glaucoma is due to forward rotation of the rudimentary iris stump obstructing the anterior chamber angle, and this is particularly common following intraocular surgery. Sturge-Weber syndrome is characterized by ipsilateral occurrence of facial cutaneous hemangioma as seen here in this photograph, and also known as port wine stain, choroidal cavernous hemangioma, and leptomeningeal hemangiomatosis, and it is not known to be inherited, and as many as 70% of patients with Sturge-Weber syndrome develop glaucoma, and the risk increases with involvement of the upper eyelid, the episclera, the iris, and the choroid with the hemangiomatous lesion. Glaucoma and Sturge-Weber syndrome can occur early in life or later after first decade of life. Early onset glaucoma in Sturge-Weber syndrome is said to occur due to maldevelopment of angle structures, but even in these patients, response to angle surgery is less than in primary congenital glaucoma. Late onset glaucoma following Sturge-Weber syndrome is due to elevated episcleral venous pressure, and filtration surgery in these patients is associated with a higher risk of choroidal effusion and hemorrhage. Neurofibromatosis type 1 patients can develop glaucoma, but type 2 neurofibromatosis is not known to be associated with glaucoma. Neurofibromatosis type 1 is characterized by cutaneous neurofibromas, which may be associated with ocular lesions such as leash nodules, prominent corneal nerves and ectropion uvei, CNS lesions such as optic glioma, and skin abnormalities such as cafe au lait patches and axillary and inguinal freckling. Neurofibromatosis type 1 occurs due to an autosomal dominant mutation in NF1 gene. But in comparison to the other entities, occurrence of glaucoma in NF1 is much less common, but the risk is higher in patients with plexiform neurofibroma of the upper eyelid, as seen here in this photograph. Early onset glaucoma in neurofibromatosis is said to be due to maldevelopment of the angle structures, and glaucoma occurring later is said to be due to infiltration of the angle structures with neurofibromatous tissue. And angle surgery in neurofibromatosis associated glaucoma is less successful than in primary congenital glaucoma. Up to 50% of patients undergoing surgery for congenital cataract can develop glaucoma, and this is termed as glaucoma following cataract surgery, or GFCS. GFCS is usually open angle in type with significant pigment deposition on the trabecular meshwork, but it can also be angle closure in mechanism due to an enlarging Sommerins ring pushing the peripheral iris forwards due to pupillary block or due to peripheral anterior synechial angle closure. But prior to cataract surgery, no gonioscopic difference can be found between patients developing glaucoma after cataract surgery and those who don't. Glaucoma usually develops within the first 3 years following surgery for congenital cataract, but may develop anytime later in life, and so patients undergoing surgery for congenital cataract early in life requires lifelong follow-up, and this is very important to remember. Risk of developing glaucoma following surgery of congenital cataract increases when cataract surgery is done early in life, particularly if done within the first 6 weeks of life, when the patient has a small corneal diameter and when additional procedures need to be done following the cataract surgery. But the risk of glaucoma is same whether the patient is left aphakic or an intraocular lens is implanted. In addition to glaucomatous optic neuropathy and corneal scarring, sequelae of pediatric glaucoma includes myopia, astigmatism, anisometropia, lens subluxation and cataract development, a thin fragile sclera which is prone to rupture with mild trauma, amblyopia, strabismus, and recurrent IOP elevation which can occur years later. To recap the salient points, pediatric glaucoma is defined by the Childhood Glaucoma Research Network as clinical conditions having two or more of the following: glaucomatous optic neuropathy, which is typically a generalized enlargement of the cup when the onset of IOP elevation is before 4 years of age; corneal changes such as corneal enlargement and Habs striae when the onset of IOP elevation is before 4 years of age; progressive myopia till 10 years of age; glaucomatous visual field defect; and raised intraocular pressure over and above 21 millimeters of mercury. Pediatric glaucomas are classified as primary and secondary pediatric glaucomas. Primary pediatric glaucomas do not have any associated ocular and systemic anomalies. They include primary congenital glaucoma and juvenile open-angle glaucoma. Secondary pediatric glaucomas are much more common than primary pediatric glaucomas and are classified into those due to non-acquired ocular anomalies, those due to non-acquired systemic anomalies, those due to acquired systemic or ocular anomalies, and those following congenital cataract surgery. Primary congenital glaucoma is most commonly a bilateral condition presenting before 1 year of age. The most common genetic mutation detected is an autosomal recessive mutation in the CYP1B1 gene. The classic triad of symptoms in primary congenital glaucoma are epiphora, photophobia, and blepharospasm. Gonioscopy shows a high insertion of the iris and a scalloped appearance of the peripheral iris. Treatment of primary congenital glaucoma is primarily surgical, and if IOP is controlled before 4 years of age, there can actually be a decrease in the cup-disc ratio, which is called a reversal of the cupping, but any pre-existing RNFL atrophy and consequent visual field defects persist. Differential diagnosis of primary congenital glaucoma include nasolacrimal duct obstruction and epithelial defect which may cause epiphora, megalocornea and axial myopia which may cause corneal enlargement without glaucoma, forceps injury during birth which may cause tears in the decimates membrane, corneal infections, corneal dystrophies, and metabolic disorders which may cause corneal opacification, optic disc anomalies such as optic disc pit and optic disc coloboma, and secondary pediatric glaucomas. Juvenile open-angle glaucoma has by definition an onset between 4 and 40 years of age. It may present with progressive myopia. Most common genetic defect in juvenile open-angle glaucoma is an autosomal dominant mutation in myocilin or MYOC gene. More than 50% each of patients with Axenfield-Reiger syndrome, Peter's anomaly, Aniridia, and Sturge-Weber syndrome can develop secondary glaucoma. And glaucoma following pediatric cataract surgery is the most common form of secondary pediatric glaucoma. Thank you for listening.